Hi, my name is Shabir Moosa. I'm going to talk to you about mental health and the potential use of ketamine. Firstly, I want to share a conflict of interest. I'm medical director of AYZA Health. I think there might be critics out there who say that this off-label use of ketamine is dubious, but I think that we also need to understand the conflict of interest where drugs that are manufactured get so much more in the way of resources that can show its benefit. This drug does not that same benefit, so I hope one gives it fair thinking. I also want to say that I've had personal experience with ketamine, and that has made me a strong believer. My experience has been that I've had depression, anxiety, and in fact that presented itself as fatigue and then dizziness for quite a few years before I realized, after much investigation, that it was actually depression and stress. And then I had been on antidepressants for a while and realized that going from one to the other is not producing anything. I'm on Cipralex double dosed at maximum, and that was for a couple of months until I tried ketamine, and voila, 24 hours, there was a big major difference. So that personal experience is mine to share. I also think that when we're looking at it, we need to have the best in evidence, and I'm going to share with you what is there in the way of systematic reviews and meta-analyses. And I think one needs to be aware that there's a lot of um, evidence out there that hasn't been put together strongly enough, that need better um, collection and better doing. So I hope that one is going to get this improved dramatically over the next few years. It certainly has been dramatic when you look at the studies I share in the last few years. So just to give you some background, that Craig found in 2022 in a national survey in South Africa, that mental health is a big problem. We've known that for many years, but I think it's very notable that almost 25% or more than 25% of people in South Africa have clinical depression based on the PHQ-9. They also have quite high levels of anxiety using the GAD, Generalized Anxiety Disorder Questionnaire 7. This compares very poorly to other countries, like in the US at 6.9%, or the most recent one in Brazil at 7.9%. And we're almost 2 or 3 times worse than those countries. What has been found in South Africa, that those people most at risk are actually those who are retired, those over 65 years, widowed, divorced, separated, and living in metropolitan areas, and those with only primary school education. I'm going to go through a background. We all know that usual therapy, and I'm not going to go through it, although medication is a mainstay today, with the SSRIs as being the most recent kid on the block. There have been newer treatments like the serotonin norepinephrine receptor inhibitors, and then new atypical antidepressants that have come on the market, some of them quite old, and antipsychotics, where psychiatrists are considering the use of it in depression, with 25% of depressives having psychotic features. Psychotherapy is in fact a mainstay as well. Some of the newer therapies, and I'm not going to talk about it today, but it's cognitive and dialectical behavior therapy, very useful, atypical for psychologists, but a very useful way of dealing with patients with emotional challenges. Then I'm going to talk very extensively about ketamine therapy and see how what the evidence suggests about it. Ketamine was discovered in 1965, and it was approved for clinical use in 1970. It's a safe intravenous anesthetic. It interacts with a number of receptors in the brain. It has, unfortunately, the unpleasant side effect of dissociation, which many patients who go through anesthetic don't particularly enjoy. It's still it's declined in use with newer anesthetics like propofol, but it's still considered a WHO essential medicine for both developed and developing countries. The ketamine has garnered new interest in the last few years, probably more so in the last decade, but it's been since 2000. And it's potentially in alternative clinical settings such as depression, especially in suicide. And I think this is the real big focus with lots of studies to show benefit, but also somewhat in bipolar disorder, in anxiety disorder, particularly social anxiety disorder, PTSD, substance abuse or substance use disorders. It's also been shown. It's long been used for chronic pain, with a lot more work being done around that and other conditions which have a neurological element, and one notably as COVID, long COVID, which is considered worthy treating with this, and a few case studies that show its benefit. As opposed to the various SSRIs and other monoaminergic drugs, this ketamine works within hours rather than weeks. It also lasts after the infusions, whether single or multiple, usually 6 over 2 weeks, 2 to 3 weeks. It can last up to a month, but the long-term effects are not yet fully understood. And these are the studies that have provided some very useful background. The mechanisms of action is still something that's not entirely clear. There is certainly an increased circulation in the limbic system. It's certainly lends itself to the immediate dissociative effect, the thing that appeals to those who abuse it, but that is also important in the process as a measure of the impact on depression. But the monoaminergic systems are those that are affected by serotonin, norepinephrine, and dopamine, and these take several weeks of daily administration to take effect. Whereas in the glutamatergic systems, and that's ketamine, having an effect on it through the N-methyl D-aspartate receptor antagonist, receptors being an antagonist of it, leads to a glutamate surge in the synapses. And this lends itself to postsynaptic signaling that then gets a protein cascade, especially brain-derived neurotrophic factor, or BDNF, and this increases, quite importantly, the synaptic plasticity and dendritic spines. So in other words, it helps your brain to actually shift and reconnect in some way. So it's quite easily seen as a brain reset. It also affects the other two major neurotransmitter systems in the brain, the opioid and the cholinergic systems, but less so. Depression is certainly the one where most of the justification is there. They started off with the seminal study by Burnham in 2000. There's been a systematic review meta-analysis in 2015 by Lee and company, and it basically came out looking at the ketamine as a novel treatment, looking at studies from 1999 to 2013, and found 5 RCTs in the meta-analysis. Of course, I'm going to mention this, that PRISMA guidelines for systematic reviews are not evident in here, but it looked at the depression, Montgomery-Åsberg depression rating scale, or the MADRS, or the Hamilton depression rating scale, HDRS. Ketamine significantly reduced depressive symptoms, and the overall effect at day 1 was very large and statistically significant, but it was sustained at 7 days post-infusion. And I think it was reasonable in terms of quality. A subsequent systematic review, meta-analysis in 2022, looked at ketamine for the treatment of mental health and substance use disorders. It's a narrative synthesis of 83 reports, but included 33 systematic reviews and 29 randomized controlled trials, and a number of others that were not in this bracket. It did apply PRISMA 2020 guidelines, and it found that there was strong evidence for the robust, rapid, and transient antidepressant and anti-suicidal effects of ketamine. The evidence for other indications that are mentioned show that they are positive, but not as robust in terms of the evidence so far. So there's clearly more research required, but the research, I think, in terms of depression, is to look at the optimal doses, the modes of administration, and the most effective forms of adjunctive psychotherapeutic support, because it's seen as much more helpful in combination. Certainly, the long-term effects with long-term therapy is also something worthy of looking at. and this study was done by Walsh in 2022. There was a second systematic review and meta-analysis 2022 by Mark and Tony, which looked at the efficacy of IV ketamine for treatment-resistant depression. Key indication for it, again, looked at multiple databases, 28 studies. This was focused on clinician-rated outcome measures, and it looked, again, it used the PRISMA guidelines as well as the Johanna-Briggs inventory to manage the quality. And they found that a single ketamine infusion had a strong effect at 4 hours, maximum effect at 24 hours, but the effectiveness of the ketamine was still present at 7 days post-infusions, with the multiple infusions actually enhancing and prolonging the effect. Although in this study they did not look at the measures after 7 days. Clearly there's a need to look at the long-term safety and efficacy, and I think that's really a key piece of work that needs to be done. Suicide is, again, the second clear indication for it. There was a systematic review in 2018. Single dose of IV ketamine reduced suicidal ideation for up to a week. It, in fact, was not entirely it was partially independent of its effect on mood. A second systematic review in 2021 by Hochschild found 11 RCTs, and again found that there was a good advantage of ketamine over the control in rapid reduction of suicidal ideation. And the IV ketamine, racemic ketamine, is in fact the most effective. A meta-analysis in 2021 found both associated with reductions in suicidal ideation, 2, 4, and 24-hour post-intervention. So it's certainly something useful in the instance of use of suicide. There is obviously a comparison with ECT, and a systematic review was done in 2020, looking at it compared to ECT. There was no superiority of ketamine over ECT for the severity of symptoms and response to the therapy, but the side effects were significantly different, especially the risk of muscle pain with ketamine. Anxiety is probably a less of an indication, but there's some interesting studies that suggest its usefulness in certain conditions. A systematic review in 2021 by Whitaker looked at the effectiveness of ketamine in treating refractory anxiety spectrum disorders. There were 6 RCTs, some in social anxiety disorder, and then PTSD, and then OCD as well. It's a qualitative synthesis with some quantitative analysis as well. Clearly, the acute ketamine seemed to be broadly effective against anxiety, with a key dose-response profile observed for ketamine in terms of changes in the social anxiety disorder. So the higher the dose, the more the social anxiety seemed to be improved. And this seemed to be prolonged with maintenance treatment in the work done. Another study, a systematic review in 2021, looked at it again, and this produced 8 studies looking at RCTs and then some for cases. Often there were small samples, but many a times in these RCTs there were quite big effect sizes, so the sampling itself was not material for the fact that there was quite big effect changes. The anxiety symptoms did return to baseline in these cases in this systematic review after 2 weeks. Again, the dissociative effects and mechanisms, basically the psychoactive properties of ketamine may also be contributing in itself, but clearly the drug itself lasts only 4 hours in the body. So this is clearly a change to the physiology of patients. PTSD has been found to be probably a more useful besides social anxiety disorder, and its usefulness has been found there with an RCT in 2021 looking at repeated ketamine administration for chronic PTSD, and this found a significant improvement in these scales versus midazolam, which is the standard control in ketamine studies, where more than 3 times an effect was achieved in the ketamine group. It's of course the duration that it lasted was in fact around a month, after 2 weeks of infusions. And usually in the long-term management of it, it's not a repeat of 2 weeks, but a single maintenance dose that tends to keep the effect happening based on multiple case studies that have been published. This review, there was another review in 2023, which showed the potential use as well, looking at a number of case studies and to randomized control trials, and found that it is encouraging, but there are clearly methodological problems in the research on ketamine. And I'll share some of the difficulties in the research later. Obsessive compulsive disorder is not a very, not much studied, but it has a ketamine systematic review in 2022 based its premise on the fact that the pathophysiology of OCD tends to be glutamatergic in terms of its neurotransmission and effect. But 9 articles, based on Prisma guidelines, found that they, only using the single session IV ketamine, that there was limited evidence for ketamine and psychotherapy. But clearly there's room for study. Substance use disorder is another very interesting use for ketamine. A systematic review in 2018 looking at the efficacy of ketamine in treating substance use disorders. These included alcohol, cocaine, and opioid use disorders. There were 7 studies, not all of them were RCTs. The cocaine studies showed improvements in craving, motivation, and cocaine use, but the study obviously limited by small sample sizes, homogeneous populations, and a very short follow-up. There was also improvement in alcohol and opioid abstinence rates with significant group effects for up to 2 years following a single infusion. That was one of the studies, but this was not placebo-controlled. The potential is there for ketamine to facilitate abstinence across a number of substances of abuse, and it warrants further investigation. There was also an overview of 6 ongoing studies of ketamine in the treatment of alcohol, cocaine, cannabis, and opioid use. So clearly it's ballooning in terms of how ketamine might be able to assist in this space. Another review in 2021 by Martinotti found the therapeutic potential for the ketamine in the substance use disorders, and it found that motivational enhancement therapy together with ketamine had produced significant reductions in alcohol consumption in those prone to alcohol use. IV ketamine certainly significantly reduced the cocaine use, relapse rate in cravings, and it in fact had a greater and longer lasting reduction in heroin cravings with higher doses of ketamine suggesting a dose dependence. A second review, systematic review in 2022, found ketamine for treatment of substance use disorders being positive but having short-lived effects. So clearly some work needs to be done. A single pilot trial in 2020 looking again at ketamine and motivational enhancement therapy found that this was improved the measures of drinking and alcohols with alcohol dependence. A second RCT looked at 3 infusion ketamines with relapse-based psychotherapy, and this was significantly improving the number of days by 10% that they were abstinent from alcohol. And this clearly is best in terms of trying to do group work, group therapy, or psychotherapy together with ketamine. Other conditions have also been shown to be very important, and I think one that I mentioned earlier is chronic pain. There was a systematic review of a meta-analysis 2018 looking at the efficacy of ketamine infusion in treating CRPS, which is complex regional pain syndrome, and has been found to be clinically effective in short term, but for less than 3 months. There was a Delphi study done in 2021 with experts on ketamine in chronic pain who felt that neuropathic pain was a first indication for ketamine and should be used for that purpose, but they found increasingly the usefulness for fibromyalgia, so CRPS, central neuropathic pain, peripheral neuropathic pain, nociceptive pain, sensitization, opioid withdrawal, palliative care, etc. The preferred approach is an IV 4-hour infusion repeated over 4 days with a quarterly top-up, and this obviously combined with non-pharmacological treatment. There was found to be very adverse events with such a long use of ketamine, and it certainly is looking. There's certainly a lot of case studies that are emerging showing its value in long COVID, especially with the neuropsychiatric problems that are there with it. The experience that the patient goes through with a low dose, and this is far lower than is used in the anesthetic as an anesthetic. Essentially, it induces time and space distortions. It can produce hallucinations, but really it does produce strong dissociation. In fact, that's an indicator of its effect on the as an antidepressant. And essentially, it leads to a person having to dissolve themselves or lead to ego dissolution. And that's found, this dissociative effect is found to be particularly important as opposed to the derealization that occurs with the dissociative effect that comes with ketamine. Obviously, there are challenges in using ketamine. It does produce nausea. Often it's given with an antiemetic. It can produce a headache an hour or so later. There are certainly risks, and this is why it should be given in a monitored environment with vital monitoring through that process. It has basically the biggest problem is that it leads to more hypertension, and this is the kind of effect at maximum at 30 minutes being a relatively small impact on systolic and diastolic pressures in terms of blood pressure increase over a number of infusions. Its addiction is not necessarily true. It certainly is an addictive drug, but probably more than its physical organic addiction. It's a psychological addiction, but there's no evidence for the clinical administration in low doses, as is used in this infusion, actually inducing any addiction. But clearly it needs to be a controlled substance and used with clinical discretion. In addiction, in places where it is abused, like in Singapore, they have found that it does produce a cystitis. There are other risks, but they're really marginal. These are the major challenges. I think it's really important that we appreciate that as a drug, research for it is challenging. There are other dissociative drugs, but they're all illegal at the moment. It is only the one that at the moment is allowed for off-label use. It is challenging to blind because a patient who experiences this can share that and easily unblind controls if they interact with them or with the caregiver. So it does present challenges in terms of creating an appropriate control for RCTs. So there might be this expectancy that drives the difference in outcomes. Nonetheless, I think the search is on to look at options beside midazolam to be able to look at something that could serve as a placebo without the effect of on neurotransmitters. This space is regulated. The South African Society of Psychiatrists have actually approved its use for treatment-resistant depression, and that's the clear indication in the outpatient setting. It also has some very useful spaces for inpatient setting with suicide, and I think that these are the sort of uses for which it should be considered primarily, and others, on a research basis. It is also regulated both in the US, Canada, with growing number of guidelines that are produced to guide its use as well as guide its the facilities and providers that are implementing this therapy. So KEPSA is the Society of Ketamine Practitioners in South Africa, and I am on the executive board of it, and that is the idea to try and build a consensus group of practitioners who can set the bar for both the certification and the practice of this. The access is certainly something that we need to manage. Obviously, there is a referral network that we are actively seeking out. It's open to self-referral, but we, in fact, will be looking at doing that in collaboration with our network of psychologists, psychiatrists, and other healthcare providers who can work with us on a multidisciplinary team approach with this patient. We also want to try and work with our network on research, looking at particularly the long-term impact, as well as a common element of depression, common type of depression, those with psychotic symptoms, and something that's really interesting in terms of going forward. So thank you very much. I hope this has been useful for you to understand the space of ketamine therapy. You can certainly communicate with me at Prof. Moosa at ayzahealth.co.za and visit the website of AYZA Health at ayzahealth.coza. Feel free to Google and search out. There's all this research that I've referenced is there at the website on the professional web page, and this presentation as well as the slides will be available at that website. Thank you very much for hearing me, and I hope you will refer to us. Thank you.